Our next presenter is an epidemiologist at the Tennessee Department of Health. She's going to talk about syringe service programs in Tennessee. I have had the pleasure of working with her on the SafePoint syringe service program. Her name is Allison Wilhelm. Allison, are you there?
I am here, yes. Can you hear me?
I can. Are you
Perfect.
ready to go?
I am, yes. I will attempt to share my screen.
All right, looks good. The stage is yours. And I will put the link to the evaluation and credit for Allison's presentation for CEs in the chat box. And you can put your questions in the Q&A and we will answer them for about the last 10 minutes. So y'all feel free to put questions in while she's speaking and we'll get to them at the end.
All right, excellent. Thank you, Josh. Can you see my screen?
Yes, we can see it.
Oh, perfect. All right, and thank you for the introduction. As Josh said, so I am one of the epidemiologists in the HIV prevention program at the Tennessee Department of Health, and part of my role in that role is to also serve as the syringe services program liaison for the state. So I help provide a lot of technical assistance to SSPs or syringe services programs or agencies who wish to operate SSPs. And I'm also kind of serve as the first set of eyes on any applications that we may receive. So I'm excited to be here today and thank you for the opportunity to allow me to speak. So real briefly, I am going to be touching on, first off, what are syringe services programs or SSPs, then going to be reviewing some benefits, best practices, and kind of what we would hope to avoid in operating SSPs. Then I'll briefly go over 4 of the main SSP models, and then describe the need for SSPs here locally in Tennessee, and then also review our legislation and application process, and then some of our key metrics and outcomes that we really look at. So first, what are syringe services programs? So syringe services programs are a community-based public health program that provide comprehensive harm reduction services. So it's really more than just the exchange of the used and unused syringes. So all of our SSPs here locally provide sterile needles, syringes, and other injection equipment to participants or clients. They also provide safe disposal containers for needles and syringes. So we acknowledge that sharps containers, can really add up quickly. And so a lot of our SSPs have also gotten pretty creative in looking at, what does safe disposal really look like? And so that could be distributing laundry detergent bottles to folks, or any kind of hard plastic. Our SSPs also provide HIV and hepatitis testing and linkage to treatment. In those SSPs who might not be able to offer HIV or hepatitis C testing right on hand, they've really done a great job at collaborating with other community-based organizations so that maybe someone from that community-based organization can provide testing for them. And they also provide education about overdose prevention and safer injection practices and what that might look like. Referral to substance use disorder treatment, and I think what's really important to note here is that they provide those referrals when someone is ready. So they are not by any means, forcing anyone to get linked into any kind of treatment that they aren't ready for. Referral to medical, mental health, and social services. So really wraparound services, right? So more than just substance use disorder treatment, primary medical care. And then also teaching them tools to prevent HIV, STIs, and viral hepatitis. SSPs were born out of activist response to a crisis. They were a grassroots effort that began when persons who inject drugs themselves started using unused syringes among their peer group before it became evidence-based. So as of now, CDC has deemed SSPs as an evidence-based intervention, I guess, or program, if you will. Some of the first SSP started in Holland in the 1980s in response to a hepatitis B outbreak. And then the first known United States SSP started in Tacoma in 1988 in response to the AIDS crisis. So now on to some of the SSP benefits. So basically just kind of try to debunk some of the common myths, I guess, if you will, about SSPs. So they do often reduce drug use, not necessarily a primary goal, but it is often a result of someone attending an SSP just by providing education and resources that folks might not receive elsewhere. So persons who inject drugs are also more likely to enter into treatment for substance use disorder when participating in an SSP, and are also more likely to reduce or stop injecting when they use an SSP. And so this is, again, kind of just getting at that, you know, SSPs are really touching a difficult to reach folks. And these, you know, the clients are really just receiving services that they may not otherwise have received. They also reduce needle stick injuries among first responders, and that's simply by providing proper disposal of their used syringes or works, and also by providing education. And then they also reduce HIV and HCV, or hepatitis C virus incidents, and that's by preventing the reuse and sharing of needles and any additional works. They do not increase local crime in areas where they're located. And then they also reduce overdose deaths by educating persons who inject drugs how to prevent and respond to a drug overdose. But not only that, but by also providing naloxone. Our SSPs provide naloxone free of charge to all of their participants, and even folks who just may need it in the community. They also save healthcare dollars by preventing infection. And this isn't just HIV, hepatitis C, but also bacterial infections such as like endocarditis. And last but certainly not least, kind of what I've gotten at the last couple slides, but they're more than just syringes, right? So we're connecting folks to much needed services that otherwise they wouldn't be connected to these services. All right, so some of the SSP best practices and what we might want to avoid. So some characteristics of effective SSPs, we definitely want to, our goal is to ensure a low threshold access to services. So this could mean operating hours. So some of your participants may not be able to come. They might have a traditional 9-to-5 job and might not be able to come during the workday. Maybe being a little bit more creative and offering services in the evenings, maybe once or twice a week. Or location. It's very important to make sure that the location, meets where the people who you're wanting to serve. So it also coordinates linkages to healthcare and other social services. So like I was getting at earlier, primary healthcare, that's very important. Housing might be a concern for some of the clients, or food, linking them to a food pantry or transportation. So just being able to have those wraparound holistic services. So it's more than just the syringes. It definitely includes a diverse community stakeholders in creating a social and legal environment supportive of SSPs and persons who inject drugs. So really making sure that affected people have a seat at the table, as well as getting the champion law enforcement at the table as well, just to make sure that there's a diverse stakeholders in creating the program. It includes participants in improving and building on existing services. And this one's huge. So making sure, I know a lot of our SSPs currently are, they do like internal program evaluation to really see what their participants like about the program, what could be, a little bit improvement. So that's a huge one, just making sure that your participants have a voice that is listened to. Exactly, so the last bullet, so ensures that persons who inject drugs definitely have a voice that is heard and responded to and a seat at the table. So some practices to avoid. So supplying single-use syringes, meaning that the needle will retract up into the barrel after one use. That just really kind of implies that persons who inject drugs aren't able to make healthy decisions or good public health decisions, and just we try to avoid that. Limiting frequent of visits and number of syringes. So if your program were to operate 3 days a week, only allowing someone to operate, only allowing someone to come visit the program 1 day a week. Try to avoid that as well. Also the number of syringes, and kind of relatedly, requiring a one-for-one exchange. Our Tennessee legislation requires that we strive for a one-for-one exchange, but doesn't necessarily require it. And so while we want to collect as many syringes as we can, we like to avoid absolutely requiring it. So along the same line, so restricting syringe volume with unnecessary maximum. So this is also, there's a caveat to this because funding is very limited for needles and syringes, but only allowing, saying that you can only distribute, 50 syringes per visit. We try to avoid that just because someone might need more than that, and we want to prevent folks from having to reuse their syringes. And then requiring identifying documentation is huge. A lot of folks don't want to provide any unnecessary information, and then that could also be a barrier of them receiving services from your SSP. And so while I'm in EPI, and so it's very, very hard for me to not want to collect as much data as possible, this could really be a barrier in folks receiving services, right? And we want as many folks who need these services to receive them. And so there's really limiting the amount of data that's collected. And then also requiring any unnecessary documentation information. So kind of what I was getting at earlier, just making sure that the data that you're collecting is really valuable to your program evaluation and the services that you're providing folks. All right, so now I'm going to jump into some of the 4 primary SSP models. So the 4 models are storefront, mobile, peer-based, and pharmacy. The 2 models that we have here locally in Tennessee are storefront and mobile. So storefront meaning that your SSP is being operated out of like a brick and mortar building that has like street level access, essentially. So very straightforward. A mobile unit is any exchange occurring within a mobile van. But here locally, because of our zoning restrictions, which I'll get into a little bit later in the presentation, but due to our zoning restrictions, mobile units still have to have a set predetermined location where they will be. So here the SSPs that operate out of like a mobile unit or even out of like a tent or something like that, that aren't like your traditional storefront are still in a predetermined location. And then there's peer-based SSP models, which essentially is someone coming to the SSP and asking for syringes not only for themselves but for also their peer network, and then they'll distribute to a wide array of folks. And then there's pharmacy based SSP models, which is simply just an SSP operating out of a pharmacy. All right, so now I'm going to dive into some of the need for SSPs in Tennessee. So we are home to one of the highest opioid prescribing rates in the US. I believe it's the 3rd. About 94.4 opioid prescriptions per 100 persons, excuse me. Our drug overdose deaths have increased drastically since 2013. And this is a number that we know is very underreported, just simply due to the reporting mechanisms for overdose deaths. and death certificate data. In 2016, CDC identified 41 of the 220 U.S. counties that are most vulnerable to the rapid spread of HIV or hepatitis C among persons who inject drugs. So we're home to 41 out of those 220 U.S. counties. And then kind of what I got at earlier is that SSPs are a proven effective HIV and hepatitis C prevention strategy among persons who inject drugs, and are now evidence-based. So it just really kind of emphasize the need that we have here locally. All right, so now I'm going to dive into what our legislation looks like and then also the application process. So our SSP legislation was signed into law May 18th of 2017. Our initial legislation allowed non-governmental organizations, when first approved by TD8, to operate SSPs. And then what I was getting at earlier about the zoning restrictions, so the initial legislation also required SSPs to operate at least 2,000 feet from schools and parks. So that's about a half a mile, give or take. And so especially in our metro areas where we're really trying to build up greenway space, and rightfully so. So let me back up a little bit. So greenways also were kind of the umbrella under the umbrella of being a park. So it was really a huge barrier for our metro areas to really find a good location that would meet the client's needs as to who they were trying to serve, but then also meet the legislation's requirements. And so then May 15th of 2018, there was an amendment that was signed that also allowed local health departments to operate SSPs. They also have to be within the zoning requirements. And then the amendment also reduced zoning restrictions from 2,000 feet from schools and parks to 1,000, but that was only in Shelby, Hamilton, Davidson, and Knox counties. So the legislation requires that programs provide needles, syringes, and other injection supplies, meaning cotton, cookers, tourniquets, to their participants at no cost. They are also required to provide disposal to their clients at no cost. So like I was saying, could easily be a sharps container or a laundry detergent bottle or like a hard Gatorade bottle, any type of hard plastic. And they're required to provide educational materials to their clients. So educational materials on HIV and hepatitis C prevention, transmission, safer injection education, and how to respond or how to identify and how to respond to an overdose. They are also required to provide access or referral to naloxone. All of our SSPs are able to provide access to naloxone directly to their clients at no cost, and that is a huge, huge, huge thanks to the regional overdose prevention specialists. They've really been a huge partner to our SSPs and being able to provide the naloxone to the folks who need it. They're also required to provide consultation for mental health or addiction treatment, and then provide SSP participants as well as staff and volunteers a verification card, and that's simply to protect folks from the limited immunity that is written into our legislation. So if someone is pulled over in transit to or from an SSP and gets pulled over with or has possession of syringes or any other injection equipment, they should not be charged for the possession of those items, but that is only if they have that card on hand and if they are in transit to or from an SSP. So that's been a huge educational component for law enforcement, and definitely having to educate law enforcement when operating hours are. So, law enforcement knows if if someone's, driving and gets pulled over at 2 a.m. in the morning or something like that and tries to show the card, that, they wouldn't be in transit to or from an SSP. All right, so how to become an SSP in Tennessee or an approved site. So in order to become an approved site, agencies are required to submit an application, and we accept applications on a rolling basis. And so within the application, agencies are required to submit the type of SSP that they're proposing to operate. So here locally, it would either be whether they're proposing a storefront SSP or a mobile SSP. And so then where the SSP where will operate activities. And this is just to confirm and ensure that the location meets the legislation's zoning requirements. And then we also ask that the program confirms that they will operate under a strive for 1-for-1 needle exchange policy. And then they must provide an example of their security plan. And this is simply just to make sure that staff as well as clients are, are protected during operations. And then an naloxone referral plan. So if they won't be able to provide naloxone directly to their clients, who will they refer or where will they refer clients to get naloxone? And then also an example of the participant card that I was describing earlier, and that's just simply to protect both or all clients, staff, and volunteers from the limited immunity. And so then once agencies are approved, they are required to report annually, and those they're required to report the services that they provided. So how many syringes were distributed, how many were collected, how much naloxone was distributed through the program. They're also required to report referrals. So how many referrals were given for substance use disorder or any other, mental health services, social services. And then lastly, required to report HIV and hepatitis C testing numbers, as well as the outcome of those tests. So some of the agencies or some of the SSPs are also receive the Tennessee Department of Health funding, and those agencies are actually required to report to us monthly. And it's very similar reporting metrics that we require. So here are some of those outcomes from those funded SSPs. So we currently have 5 SSPs. A Better Way and Memphis Area Prevention Coalition are both located in Memphis. And then we have Simba Community Care, who is located in Chattanooga. And then they also have a site in Johnson City, and that's in partnership with the ETSU HIV Center of Excellence, and then StreetWorks, which is in Nashville. So you can just kind of see, this is an overview of some of the services that are provided through the programs. And this is just kind of, again, another snapshot that this is more than just the syringes, right? It's also HIV, hepatitis C testing, distributing safer sex supplies, so condoms, lube, and then also naloxone distribution. So this is kind of a snapshot or a visual of our where our SSPs are located against the our HIV hepatitis C vulnerability index that Tennessee Department of Health conducted last year. And you can kind of see that this is a really good visual that shows that as of right now, our SSPs are really located in the more metro areas. We're really trying to expand to our more rural areas that are in need. And the darker blue indicating, or the darker shade of blue indicating the high vulnerability of rapid dissemination of HIV and hepatitis C among persons who inject drugs. So where we are now, so we first started collecting data in February of 2018. So through the first quarter of this month, our SSPs, and again, this is, or I'm sorry, the first quarter of this year. This is only representative of the SSP or the TDH SSPs. And that's simply because the two Memphis SSPs did not get approved until later in 2019. So they did not report to us this year. So we have distributed over 2.1 million needles and syringes. We've collected well over 1.6 million, and then distributed over 58,000 naloxone kits. So this is really incredible work that's being done in our communities. So during the same reporting period, and again, this is only the TDH funded SSPs, they performed over 2,000 HIV tests and over 1,700 HCV tests. And I think this is really important to note that our testing efforts has really increased before COVID, so later 2019 have really increased, particularly because of the HIV tests. We were allowing SSPs to provide or to conduct the INSTI test. So folks would only have to wait 1 minute versus having to kind of stay at the SSP for 20 minutes for the Aura Quick. Another thing that I would like to direct your eye at is the positivity rate for HCV. That's just an incredible rate, and has really translated into linking folks into care. So that is it. I'd like to open it up for questions.
All right, well, we've got a few. Are you ready?
Yes.
All right, Jay Villanueva says, in some European countries, needle exchange services have explored the idea of distribution of clean needles through the post. I'm assuming that's what they call the mail in Europe. What roadblocks would prevent the United States from following these countries from creating comparable means of distribution?
Yeah, so there actually is a program that in the US that does do mail-based. It's Next Distro. I think the website is nextdistro.org if you'd want to look into more about her program. I know locally is our legislation and the zoning requirements requiring SSPs to operate, within either 1,000 or 2,000, dependent upon location. That is our local barrier, but there actually is a program in the U.S. And I think it's one of the first, if not the first, that does do mail-based exchange and naloxone distribution.
All right, and someone asked, how do you navigate the stigma of SSPs in communities, attitudes such as not in my backyard, you're promoting use, you're providing paraphernalia, that kind of mentality?
That has been an uphill battle for us. I think as the Department of Health, as well as for SSPs, it's really just education and awareness and just being very consistent and persistent. And Josh, I don't want to put you on the spot either, but I know you probably, helping out with the SSP might have some firsthand knowledge of this as well, or anything specific that you've done that you thought that our Memphis Area Prevention Coalition has done that you thought was helpful.
Yeah, well, I mean, I think the biggest help is education. I think, the facts are that there have been studies done. This is evidence-based. It is helping people get into treatment. It is not keeping them from getting into treatment. The idea that people are going to do more drugs because they have needles or naloxone is ludicrous.
Yeah.
Someone with substance use disorder is going to continue to do that anyway.
Exactly.
And also, there's studies out of DC and New York, you probably are aware of them, that showed that amongst the IV using community, new instances of HIV were reduced by 70%. And I think they tabulated it, and it was saving them something like $200 million a year for lifetime treatment of HIV, which is, a staggering number.
Yeah.
So, I think, in my personal opinion, is that we let, the community know what's going on and why we're doing this, and that in the long run, it's helpful to them rather than harmful. Amy Bechtel is asking, how do law enforcement respond? Are they supportive? Do they see the value?
Yeah, so it really varies across the state. So for example, whenever they were first signed into law, prior to any agency becoming an approved site, we basically had a roundtable discussion and brought together the local health department, the law enforcement, and it really became a lot. And that's kind of why we veered away from doing that, just because it's very, very, very time consuming. But like, for example, for Nashville, law enforcement is super, super supportive. So in the more metro areas, I think they tend to be a little bit more supportive than in the more rural areas. So it really varies across the state. And I think it's just really, really important to find, that champion in law enforcement that really is supportive of SSPs, and hopefully will then educate his or her colleagues about the work and the need and the importance of them.
Is there a difference in implementation in rural versus urban communities?
I guess can whoever asked that question, can you expand, I guess, on that a little bit more?
Well, I think the question is the implementation in areas where the population is more widespread.
Yeah.
And not condensed.
So I think the services will essentially look the same, but I also think that this is really where you just really want to make sure that you're using the community that's being served to have a voice, and of having so asking, because I know Choice Health Network, for example, who's in Knoxville, they also recently expanded to Cott County, which is a more rural area. Before setting a location, they really took the time to ask the community where would be a good location. And they were very cognizant of making sure that the location would meet the community's needs. And so I think being more spread out, you really need to make sure that the community has even maybe more of a voice in like location and hours that would meet the needs. But essentially the services are the same.
Yeah. Is there any, do you think like a mobile versus brick and mortar makes a difference in those areas?
I definitely think in the more rural areas, it might be ideal to have mobile, just simply because you could hopefully kind of hop around, a couple different locations each week, and then hopefully being able to serve more folks in a wider, area.
Yeah. But we currently, I'm looking at another question. We currently do not have a mobile service that drives out to rural counties and delivers the service, correct? In Tennessee.
So not right now, like I said. So Choice Health Network just recently started a program in Cott County, but that's, as of right now, that's really the only more rural area that's being served.
Okay. What about the faith community response? Have you seen any involvement there?
Not as much as what we would hope or want. I know Choice Health Network actually, again, in Cott County, they really collaborated with a faith-based organization there. but no, not as much as what we would hope for.
Okay. And another question. So does this cause more needle debris in drug areas causing injuries or needle sticks?
No, because all of our SSPs provide safe disposal to their clients. I mean, it actually reduces the amount of used syringes that are found, like in parks or other places where people might use, and it actually reduces needle stick injuries as well, simply because clients are now provided a space to provide, or I'm sorry, to dispose of their used syringes properly.
Right. What are the biggest barriers to start or implement an SSP?
In general, funding is a huge barrier. That's really in general. There's just not, in my, I'm sure, biased perspective, not near enough funding for SSPs, not only here locally, but also the US. And I apologize, I probably should have put this in or provided this in my presentation, but there is a federal ban to purchase syringes or needle syringes and cookers with any type of federal dollars. So any type of funding that we meaning the Tennessee Department of Health, is to announce it cannot be used for the purchase of needle syringes or cookers. And so that can be a huge barrier. SSPs are definitely banking on more like private either funding or donations to be able to purchase those items.
So what do you attribute to them not putting money into items like that?
Stigma, unfortunately, stigma.
So that's stigma on a much broader level.
Mm-hmm. Yeah.
Basically saying we're not going to help people use drugs, but of course that keeps the states from benefiting, from the cost saving and the people getting treatment. Yeah. I know we're dealing with that ourselves. If someone gets arrested and has their card and still gets charged with paraphernalia, is there a process or recommendation to help those individuals?
Yes, so that has happened, as I'm sure most of you would believe. That has happened, and I know whenever that has happened or does happen, I mean, it's still actively happening. The person will, because whenever if it's like someone's first visit to the SSP, there's a lot of education around like the legality of the program among the exchanger and the client. And so I think probably providing that participant card is a huge portion of that education to the client. And the agency or the exchanger will make sure to let them know, like let the client know, like if you were to get pulled over, please let us know. We'll work with like the justice system to help like either get that charge taken off, or because this has also been a huge educational component for law enforcement. A lot of law enforcement just don't know that SSPs are, even sad to say, they just don't know that SSPs Mm-hmm.
Yeah, and we have had some of that here. It's getting a lot better here. We have a pretty good relationship with the Memphis Police Department here, and they, we've heard from some of our clients that one of them had gotten arrested, and they gave them their syringes back in their property because they had their card on them. So
yeah,
it seems to be working here.
That's good.
All right, so I'm going to put this link in the chat, and this is the link to get to the evaluation for Allison's session and to get the CEs and the certificate for this session. And we have about 10 minutes left, so if y'all have questions, please put them in now. The next question is, what are the available resources for uninsured clients that test positive for HIV?
I actually, it really, it depends. I mean, like there's Ryan White, it really depends on their financial, like their finances as well. So there's several resources though. But Ryan White would become like the first that comes to my mind.
Right. Okay. And are SSPs allowed to collect needles for individuals that inject legal substances?
Yes. Yeah. So our SSPs also provide services to folks who who are diabetic and have to inject insulin, and he can't afford or they can't afford needles, and so they actually receive the needles for the through the SSP. So that's definitely or even folks who might inject hormones. So they definitely provide services for other populations aside from folks who might use drugs or inject drugs.
How successful are SSPs in getting individuals into detox? Do you anticipate more state funding for medical detox beds in the near future?
So the funding question, I'm probably not the right person to answer that. That'd be someone probably from the Department of Mental Health and Substance Use Services. But the linkage to like substance use disorder treatment success is a really, really tricky question and metric to gauge, because if folks are getting linked to those services, they may or may not come back to the SSP for services. And so really being able to gauge that is pretty tricky. And I think that's something that, you know, we've talked about internally, is how we can maybe better gauge that. But I know nationally, SSPs are kind of trying to figure out like what kind of metric might be the best to determine that.
Yeah, we do know though that, or from what I've read, that about a person that's a member of an SSP is about 5 times more likely to help than someone who is not.
Yeah, and I think that's just largely also due to, I mean, they're getting resources and, you know, referrals to places where they would not otherwise receive those services.
Right. They know where to go. When they are to get help, they have a connection to somebody who can hook them up with the resources they need. Yeah. That's been our experience as well. And we've had quite a few get into treatment through the SSPs in Shelby County since they started.
That's awesome. I love hearing your input too.
There are a lot of students on here today that will be entering the healthcare profession. What would you say to those students wanting to get into this field to fight these epidemics such as HIV and opioid use?
That's a tough one. It's definitely it's mentally taxing. You can have really good days and you can have really bad days. And I'm sure, Josh, you can say the same. I mean, I love it because I'm also personally passionate about it. And I think that's where a lot of my passion stems from, is my personal life. But it can definitely be mentally taxing. So just be willing to kind of step back, and also self-care. Self-care is very important.
Yeah, absolutely. Yeah, and that's true with a lot of people that do what we do. There is a, you know, personal stake in and personal reason that drives them. All right, question from Jim. How do non-SSP states start the process in getting SSP services?
Advocacy. Really, you just need advocates that will try to just illustrate the need in their state.
Yeah, and Tennessee is very data driven. So I don't know about your state, but what the state likes to see is evidence. You know, they want to see proof. Why do we need this? You know, what is going on that we need this for? Here in Shelby County, the need became very obvious with our HIV rates, right? And one of the highest in the nation, actually, in Shelby County. And I think we were like 6 times our normal rate here recently. So, you know, we definitely were able to show that we had an issue. But when you're dealing with politics, it usually is, you know, you have to have done your research and you have to have evaluations or studies, numbers that show the reason why. You know, that they're not just going to take your word for it, right, Allison?
Yeah, and I mean, the initial vulnerability index that was conducted by CDC shortly after the HIV outbreak in Scott County, Indiana, among persons who inject drugs, it just really, again, to Josh's point, data illustrated, oh my, like it opened eyes, like we are home to at least like 41 of the 220 counties, you know, that are vulnerable for rapid dissemination around HIV, hepatitis C. What can we do about this then? Like what action step can we do to prevent this from happening? And it's sad to say that this also, I think seeing how much money Indiana spent on the outbreak was also another trigger.
Absolutely. All right, and how long have SSPs been legal in Tennessee, and why were they illegal for so long?
So SSPs were signed into law May 18th, I believe, of 2017. And why were they illegal so long? I don't know that I can necessarily answer that. I guess I don't think I'd be the best person to answer that. Maybe just didn't see a need. I don't think I could be the best person to answer that part.
Well, and the history too in Tennessee, didn't the first one start illegally?
Yeah, it was an underground SSP here or in Nashville.
And that's still the one that's currently running, correct?
Mm-hmm. Yeah, they're now an approved site, Streetworks.
Well, they were legitimized, and I think the whole history of SSPs, that's how it started, right?
Yeah, here in Tennessee. Mm-hmm.
Yeah. In Europe as well, wasn't it kind of done under
Yep. Mm-hmm. All underground.
Yeah. Somebody's got to do it, right?
Right. Hey, I mean, and now it's evidence-based.
All right. Well, I don't see any more questions coming in.
All right. Thank you all. I appreciate the questions, especially this being a virtual format. I really appreciate, especially on a Friday afternoon.
Yeah, absolutely. You did not have to drive all the way out here behind the podium and do this. You can do it in the comfort of your own home.
I'm actually on vacation.
Oh, is that right?
I'm filling a hotel room.
Well, again, big thank you for doing this for us.
And of course. I appreciate the opportunity.
Yes, and I imagine I will probably be seeing you sometime in the near future.
Yes, I hope so in person.
All right, well, take care, Allison.
All right, thank you.